Good morning everyone. I am Dr. Meenakshi, HOD and Professor of Department of Respiratory Medicine from Chettinad Hospital and Research Institute. We will go to our presentation. My presentation is on evaluation of sleep disorders by polysomnography, interpretation and sleep scoring. So my main objective is to make you understand and score various sleep parameters in polysomnography, to interpret and diagnose sleep disorders by polysomnography. So what is polysomnography? It is nothing but a comprehensive sleep study. It records multiple physiological parameters during sleep to diagnose sleep disorders. It is a gold standard for diagnosing conditions like sleep-related breathing disorders, periodic limb movement disorders, rapid eye movement sleep behavior disorders, etc. This test utilizes various channels to diagnose additional parameters like leg movements and snoring also. So, what is the levels of polysomnography? We have got 4 levels of polysomnography studies utilizing various channels to monitor neurological and cardiorespiratory parameters. Levels of polysomnography. Type 1 is in-laboratory technologies attending polysomnography utilizing a minimum of 7 channels. Type 2 is a similar one, but it is unattended polysomnography. That also has to have minimum 7 channels and above. Type 3 is portable monitoring with 3 or more channels including pulse oximetry and heart rate. Minimum of 4 channels including respiratory movement, airflow and SpO2. Type 4 is portable monitoring with only 1 or 2 channels including pulse oximetry. This is a schematic representation of leads in PSG. These are all the position of ECG leads from frontal, mastoid, central and occipital. These are the positions of EEG leads, frontal, mastoid, central and occipital. This is a schematic representation of various channels hooked to the patient. This is EEG, there is electroencephalogram, electrooculogram EOG. This is sensing the airflow, nasal thermal sensors. EMG, it is placed under the chin to record electromyogram to record the muscle tones. This is microphone to record the snoring. ECG to record cardiac parameters. Thoracic belt and abdominal belt to record respiratory events. Body position to know how the patient is sleeping, whether supine or lateral. Pulse oximetry to know the oximetry details. Leg EMG again to know the muscle tones. So this is how it will look when the patient is hooked to the channels. Coming to the PSG channels with sensors and purpose. See, I am not going into the details on the sensors. Electroencephalography, electrooculography and electromyography, they are useful in staging the various stages of sleep, especially rapid eye movement sleep. Then this airflow and respiratory effort channels, they help us to monitor the respiratory events. Snoring is monitored by microphone. Oxygen saturation is monitored by pulse oximetry to detect hypoxemia. Then hypoventilation is monitored by end-tidal PCO2 or transcutaneous PCO2 monitoring to detect hypoventilation. Then electrocardiography is a modified lead to, that is to monitor the cardiac rate and rhythm. Position is monitored as I already shown by accelerometer and video monitors to detect the position of the patient because AHI will change depending on the position. Then behavior, patient's behavior like sleepwalking, sleep talking, that called parasomnias are monitored by audio and video monitors. Then we need to know some terminologies. Hypnogram. What is hypnogram? Hypnogram is a compressed graphic summary of the entire sleep study, especially showing the sleep stages. So this is a model hypnogram. Then coming to the guidelines on sleep scoring, American Academy of Sleep Medicine has given us guidelines on sleep scoring. They suggest a minimum 7 channels to record the polysomnography. We need to classify wake and sleep depending on the sleep stages. Then we have to know the term epoch. Epoch is nothing but a 30-second period where you need to stage the sleep. If two sleep stages overlap in an epoch, assign whichever is more. Then coming to the scoring and interpretation of PSG data, we need to record the basics like the basic demographics like age, sex, BMI, neck circumference, occupation. Then what are the things we will be scoring? We will be scoring sleep parameters, respiratory data, oximetry data, electromyogram and video visuals, especially to look for limb movements and parasomnias. We will score ECG data and then we will score snoring as well as hypoventilation. Coming to the sleep parameters. What are the parameters we need to score? Time in bed, total sleep time, sleep architecture, sleep latency and sleep efficiency. What is time in bed? Time in bed nothing but the total period from the patient goes to bed with the intention to sleep until they get out of the bed. This is a total recording time. This is different from total sleep time. What is total sleep time? Total sleep time is the actual amount of time the patient is asleep. This will be judged by the sleep stages. It includes all sleep stages from the starting of the sleep stage, from the onset to the final awakening. Then we talk about the term sleep architecture. What is sleep architecture? It is nothing but stages of sleep, how much time each sleep stage takes place. See, you can see here, this graph here. This is the stage, wake stage, this is the REM sleep stage, this is stage 1, this is stage 2, this is stage 3. Then we need to know the term total recording time. I have already told, from lights out to lights on. That will be equal to sleep latency. Sleep latency is nothing but the time you take to go for the first stage of sleep. Then wake after sleep onset plus total sleep time. NREM and REM cycle, you should know, they occur every 90 minutes and approximately during a sleep episode, there will be 4 to 6 NREM or REM sleep stage. Then N3 is a deep sleep, that is mostly in the first half of the night. Then REM stage, that is rapid eye movement stage, that will be longer in the second part of the night. The density will be higher in the later episodes. So we will go to each of the stages. NREM stage, I told you, that occupies 2 to 5% of our sleep. So how will you diagnose NREM stage? See, it will be having low amplitude, mixed frequency from 4 to 7 Hz. Then vertex sharp pace. Can you see here vertex sharp pace? These are the vertex sharp pace. Then eye movement, if you look at the eye movement by electroocologram, see, it will be a slow eye movement, conjugate regular sinusoidal eye movement more than 500 microseconds. NREM stage 2 is 45 to 55% of our sleep. Here this will be identified by K complex, biphasic K complex. See, can you see, this is a biphasic K complex and sleep spindles. They are sinusoidal waves with frequency of 11 to 16 Hz. And coming to the stage 3, this is a deep sleep, 12 to 18% of the sleep. It will show slow activity and EEG will be 0.5 to 2 Hz and peak to peak amplitude is more than 75 microwaves. See, look at here, these are called delta waves. Then REM stage, this occupies 20 to 25% of our sleep. This is the most important stage of sleep because most of the respiratory sleep disorders, they occur during this period, movement disorders also. So how are you going to identify? This one, REM stage. See, sawtooth waves. Main important is sawtooth waves. Rapid eye movements. That's why it's called rapid eye movement stage. See here, electroocologram shows this rapid eye movements. It is recording the rapid eye movements. Then muscle tone will be very low. So when the chin EMG will show low chin EMG tone. Then there may be some bursts of activity of phasic muscle twitches less than 0.25 seconds. Then REM staging, we continue the REM staging. Once the epoch is labeled as REM, you should continue to scoring the next one as REM till there is change to other stage. Maybe it goes to N1 or N2, N3, or there is arousal, or there is a body movement, or K complexes or spindles without REM. If REM is with low chin EMG, I told you REM is with low chin EMG. If it is with K complex and spindle but low chin EMG, score it as REM sleep. Then transition epochs to be scored by low chin EMG and absent K complex and spindles as REM, while the presence of the K complex and spindles will be scored as N2. So, this is in brief what I have told you. Awake will be random waves, low voltage waves. Drowsy is alpha waves, these are the alpha waves. N1 stage is the theta waves, this is the N1 stage theta waves. N2 will show you the sleep spindles and K complexes, sleep spindle and K complexes. Then N3 deep sleep will be delta waves. Then REM sleep, these are the sawtooth waves, Continuing the scoring of sleep parameters. Sleep parameters we should note, they will change with aging and gender. See, sleep latency, VASO, N1 and N2, they will increase with age. Sleep efficiency and total sleep time, they will decrease with age. N3 will decrease only in men, and stage REM sleep and REM latency will decrease as we age. There are certain gender differences. Women will have more of N3 deep sleep, men will be having more of N1 and N2. REM stage will be same between the different genders. Then other terminologies. What is sleep efficiency, sleep latency? I told you. Sleep efficiency is nothing, total sleep time, that is based on the sleep staging by total recording time divided by 100 into 100 will be sleep efficiency. Normal will be more than 80% will be sleeping the total recording time. So, that means they are having a healthy sleep. Sleep latency, I told you, time from the lights out to the first epoch of sleep. Normally, that is less than 30 minutes. That means we will be sleeping. When you go to the bed, you are supposed to reach the first stage within 30 minutes. Then we have got the terminology REM latency, rapid eye movement latency. This is the time from the start of the first epoch of sleep to the first epoch when the REM stage comes. Normally, REM stage will come within 60 to 120 minutes, that is 1 to 2 hours. Well, there are certain conditions where the REM will be short, where you can diagnose narcolepsy. When the REM is short, you think of narcolepsy, but that should be followed by multiple sleep latency test. When people having depression will have a short REM. Then other conditions like sleep apneas, previous REM deprivation, withdrawal of REM suppressing medication can also lead to a shorter REM latency. See, long REM latency. Long REM latency is because of taking certain drugs like tricyclic antidepressants, lithium, even ethanol, or selective serotonin reuptake inhibitors, even in sleep apnea also. Then coming to the arousal index. See, what is arousal index? I told you, these arousals could be because of apneas, leg movements, desaturations, respiratory arousals, or hypopnea arousals because of snore arousal, RARA. I will be talking about RARA also, respiratory event related arousals. So, normally our arousal index is number of arousals per hour. See, normally in younger age group arousals will be less than 10 hours, that they sleep more. When the age increases like more than 60 years, it will be more than 25 per hour. So, in arousal index, you can also diagnose one more condition, upper airway resistance syndrome. It is not apnea, hypopnea. This is arousal will be more than 10 per hour, and RARAs will be more. RARAs is respiratory event related arousals, that will be more than 5 hours. Then even ECG abnormalities, suppose persons having epilepsy, even nocturnal epilepsy could be diagnosed with EEG. Then coming to the respiratory. Till now we have seen the sleep parameters, now we are coming to the respiratory parameters. We need to know certain terminologies like apnea, hypopnea. What is apnea? Apnea is entire cessation of breathing, that is That oral thermal sensor I told you, that will detect the nasal airflow. When the oral thermal sensor drops, the nasal airflow is dropped by more than 90% of the baseline. Then duration should be at least 10 seconds. At least 90% events duration should meet the amplitude reduction criteria. Here one more thing is apnea, desaturation need not be there to score apnea. Now coming to the terminology hypopnea. Here the recommended sensor is nasal pressure sensor. For apnea, recommended sensor is nasal oral thermal sensors. Hypopnea, recommended criteria. Now the latest criteria as per the American Association of Sleep Medicine 2023 is nasal pressure drop should be more than 30% baseline. Duration should be 10 seconds. At least 90% of events duration should meet the amplitude reduction criteria. One difference is initially previous criteria said there should be more than 3% desaturation or arousal. Now the latest criteria says it should be only more than 4% desaturation. I was talking about RERA. What is RERA? Respiratory effort related arousal criteria. We have certain criteria. RERA is the preferred sensor will be esophageal manometry. What are the criteria for RERA? That is nothing but series of breaths that are lasting at least 10 seconds, and this should be associated with a increasing respiratory effort. Or there should be a flattening of the nasal pressure wave. Can you see the nasal pressure waves? Here nasal pressure wave. There is flattening of the nasal pressure wave, but there is no apnea or hypopnea. It is not meeting the criteria for apnea or hypopnea, and this should always be followed by a arousal. And desaturation is not there. Note down the point, in hypopnea desaturation will be there. Here no desaturation. See, continuing the respiratory data scoring, we should score the AHI. AHI is apnea hypopnea index. This is very, very important because we need to diagnose certain conditions like obstructive sleep apneas. So, how are you scoring the AHI? What is the number of AHIs? Then what is the severity of AHI? I will come to the severity. Then as per position also we should score. Positional AHI. The positional AHI is when you are lying in the supine position, AHI will be more. Obstruction is more, so AHI will be more. So when the supine AHI is more than twice the non-supine AHI, we call that as positional AHI. Then obstructive, central and mixed, I will come to you. REM AHI. REM related OSA is, so during the REM stage, if you get the OSA, AHI, if AHI REM is more than twice the AHI non-REM sleep, then that is called REM AHI. Then longest event duration, I will be telling you about the longest event duration. Okay. So indices for scoring OSA, apnea hypopnea index. What is apnea hypopnea index? You are scoring the apneas, you are scoring the hypopneas. The total number of apneas and hypopneas per hour of the sleep time. It is not recording time, it is total sleep time. This will be recorded in level 1 and 2. This is called apnea hypopnea index or AHI. Then another thing is respiratory disturbance index. That is, this AHI plus I told you about RERA. So when you add the RERA to the AHI per hour of sleep, that is a respiratory disturbance index. Then one more thing is respiratory event index, that is apneas and hypopneas per hour. This is, please note down, this is the total recording time. AHI is total sleep time. This is only in level 3 devices. Okay, I told you severe OSA, AHI grading is done to assess the severity of OSA. See, in take adults, see mild OSA is more than 5 events but less than 15 events per hour. Moderate is more than 15, less than 30. Severe is more than 30. Why we need to do all this? Because to plan for treatment. Pediatric age group, if you take, mild is more than 1 but less than 5. Moderate is more than 5, less than 10. Severe is more than 10. How will you diagnose all these events? Obstructive sleep apnea, as I told you, the nasal sensor, it will detect no airflow. There is no airflow at all. But still, even though there is no airflow, respiratory efforts will be continuing. See, this is the thoracic channel, this is the abdominal channel, this is the airflow. Can you see no airflow, but still respiratory and abdominal movements are there. This is obstructive sleep apnea. Coming to the central sleep apnea. In central sleep apnea, there is no airflow, but no respiratory effort also. There respiratory effort was there, here no respiratory effort. So, can you see here? No, here also no airflow, but respiratory effort is also not there. Then one more thing is Chin-Stokes breathing in central apnea. See, these are the Chin-Stokes breathing. So, what are the criteria to say that it is a Chin-Stokes breathing? You will have to have more than 3 consecutive central apneas or hypopneas that should be separated by a crescendo-decrescendo change. In breathing, amplitude with a cycle length of more than 40 seconds. Another criteria is more than 5 central apneas or hypopneas per hour of sleep associated with crescendo-decrescendo pattern. This should be over 2 hours of monitoring. That is important. Then coming to the mixed apnea. How will you score mixed apnea? See, here also airflow, no airflow. But here can you see some respiratory effort is there, and then again no respiratory effort, some respiratory effort. What are the causes for this mixed apnea? It will be dual respiratory effort, means both obstruction as well as central causes like central breathing regulation is impaired. And one more thing, I will talk to you about that treatment emergent central sleep apnea. There also we get mixed sleep apnea. When you are giving treatment for obstructive apnea, central apnea will start. That is called treatment emergent central sleep apnea. See, this is mixed apnea. Can you see here? See, flow, airflow is not there, but some chest movements are not there, again it starts, abdominal movements are not there, again it starts. I told you about one longest event duration. See, look at these 2 patients, patient A and patient B. Patient A is having a higher AHI, 22, but the duration is 12 seconds. When you go to patient B, AHI is 10, but duration is 90 seconds. So, patient B will have more severe disease due to the longer duration. I was talking about respiratory disturbance index. So, that is the number of apneas and hypopneas and RERAs per hour of sleep. Usually, there will not be much difference between the AHI and the RDA. But young thin individuals are less likely to discharge rate more than 4%. So, there may be a difference between, large difference between AHI and RDA. I have already told you about upper airway resistance syndrome, where this RDA will be more than AHI. Arousal index will be more than 10 per hour. Okay. Then coming to the oximetry data. So, what are the things we are going to score? Oxygen desaturation index, mean oxygen desaturation, nadir, that is the lowest oxygen saturation, and hypoxemic burden. See, oxygen desaturation index is, so now look at the number of oxygen desaturation less than 90%. That is a number less than 90% divided by the total sleeping time in hours. So, normally it should be less than 5 hours, 5 per hour. Here you see, this is oxygen desaturation, total 346, that is 113.7 per hour. So, this is very severe desaturation. Then I told you mean oxygen saturation. Mean oxygen saturation normally it should be more than 90%. Lowest saturation normally will be more than 80%. If it goes below 80%, it is very serious. Hypoxic burden, this is the total area under oxygen saturation curve from the pre-event baseline distribution. It quantifies the frequency, depth and duration. So, here also you can see mean oxygen saturation. I told you it should be more than 90%, here it is 89.4. Then lowest oxygen saturation should be more than 80%, here it is 71%. So, saturation less than 90% is for 74 per 9 minutes, that is 41%. Why should we score the oximetry data? Because if the lowest SaO2 is less than 80%, it can lead to acute complications of OSA, like suddenly they may develop acute coronary syndrome, arrhythmia, stroke. Some of them can go for sudden cardiac death also. Then especially this ODA, mean SaO2 and hypoxic burden, they indicate that patient may go for chronic complications of OSA like hypertension, cardiac failures, arrhythmias, pulmonary hypertension, diabetes mellitus, stroke or neurocognitive functions. Then coming to the EMG data, we have seen the respiratory data, we have seen the sleep parameters, we have seen the oxygenation. I am coming to the EMG data. EMG data gives us an indication of limb movements and to diagnose periodic limb movement disorders. So, periodic limb movement index we should know in wake and also in sleep. Normally, the limb movement will be less than 5 per hour in adults. So, when will you diagnose periodic limb movement disorders? If the PLMI SI is more than 15 per hour in adults, in children if it is more than 5 per hour. Then PLMS severity index, I am not going to the details of the severity index, you should know the severity index to treat the patients. Usually what are the conditions which are associated with periodic leg movement? They are narcolepsy, restless leg syndrome, iron deficiency, diabetes mellitus, respiratory breathing disorders, even some drugs like antidepressants. So, then I told you there are monitors to watch your movements also, video visuals that is attached to the polysomnography. So, we can look for parasomnias. What are parasomnias? Like sleepwalking, sleep talking, bruxism, then REM sleep behavior disorder. REM sleep behavior disorder is nothing. When the patient is going for dreams in the REM sleep, he will be enacting the REM by some movements. Here you can see usually that parasomnias, this limb movements, leg movement, you can see right leg movement, arm movement. Here you can see here, especially in N2 stage. Then coming to the EEG data, EEG data will denote arrhythmias if any is present. Atrial fibrillations are the most common. Others like tachy and bradyarrhythmias could be detected by seeing the EEG data. Then tachy-brady oscillations. Usually, normally actually when you take the ECG, that beats per minute, heart rate if you take, normal will be, there will be variation from 60 to 100. See here, minimum is 60, but here it is 26.7, maximum is here 100, it is 149.5. What is the implication? The CVS is unstable and they can go for cardiovascular complications. One more terminology, CVHR, that is cyclical variation in heart rate. That is slowing of HR at the event onset and then speeding of HR at the event termination. See, this is baseline. Here, then slow, it is slowing, early it is slowing. Then when it goes for later event, HR, there is speeding of the HR, heart rate. Then one more thing we need to score in polysomnography, that is hypoventilation, especially to diagnose conditions like obesity hypoventilation syndrome, Pickwickian syndromes. So, how will you score hypoventilation during sleep? There should be an increase in the arterial PCO2 to a value of more than 55 millimeters of mercury for more than 10 minutes. Another criteria is there is more than 10 millimeter mercury increase in arterial PCO2 during sleep in comparison to an awake supine value, to a value exceeding 50 millimeters of mercury for more than 10 minutes. See here, see, this is the end-tidal carbon dioxide measurement, this is the PCO2 measurement. So, here you can see, it has gone up to 74, 73, 76. Of course, snoring, primary snoring, we have got microphones to detect snoring. Audible snoring that could be reported by observer or this could be detected with a snore sensor. Then no symptoms of OSA. Snoring can be there without symptoms of VOSA. There could be absence of hypopnea, apnea or eros. In snoring, sleep architecture may be normal unless they have got other sleep-related breathing disorders. Then coming to the split night sleep study, actually it is a type of overnight polysomnography. It combines both the diagnosis. You can diagnose sleep-related breathing disorders and also you can titrate the positive airway pressure during a single night sleep study. Actually, if moderate to severe sleep apnea is detected during the first portion, that is usually less than 2 hours of the study, the second half transitions immediately into a PAP titration phase. When I was talking about treatment emergent central sleep apnea, see, it is a specific form of sleep-related breathing disorder. So, you give treatment for obstructive sleep apnea by CPAP, and appearance or persistence of central apnea during the treatment is called a treatment emergent central sleep apnea. This is thought to result from various pathological features like high loop gain, low arousal threshold, increased lung stretch receptor activation and sometimes prolonged circulation time. This phenomenon is usually often transient and may resolve with continued PAP therapy. This is a sample PSG report. It shows you the sleep summary, position statistics. This is the sleep position, sleep duration, sleep information, sleep stages, then arousal history, then apnea, hypopnea statistics. These are the SpO2 statistics and pulse and BP. So, coming to the take home points, hope you would have understood the scoring and interpretation of PSG. Polysomnography, it is a gold standard for diagnosing sleep disorders by recording multiple physiological parameters during sleep. The first step in analysis is sleep staging, where the study is divided into, I told you, 30-second epochs, and this will be scored as wake, N1, N2, N3 or REM sleep. Respiratory events will be scored on specific criteria like apnea, which involves more than 90% of the airflow drop. Hypopnea is more than 30% of the drop, with the desaturation, that is more than 4% desaturation. AHI apnea hypopnea index is number of apneas and hypopneas per hour of sleep. This is the key metric for determining the obstructive severity of the VOSA. A comprehensive PSG interpretation will also include analyzing the oximetry data, cardiac arrhythmias and limb movements to assess the systematic impact of the sleep disorders.